So I try to give no statistics or talk to you about methodology or anything. We'll talk about the non-operative treatment options that are out there, which ones we think may help, which ones may probably not help. I think ultimately it's also about which ones are not harmful versus potentially harmful for you. And also the natural history. So I think realistically, and I understand I take care of children with scoliosis and adults with scoliosis that come in and you hear surgery and you think that that's, in general, some people aren't averse to it, but a lot of people think it's the kiss of death. And you want to try something that's not surgery. And I think realistically, with observation of a curve, you need to understand that it's not neglect. Once you're in our clinic, you're engaged in your care, you're not going to disappear and come back with some horrific curve that's actually going to threaten your life or your well-being. And so observation's different from neglect. We need to engage you. We need to engage your family. And something called patient activation is actually very important across all medical disciplines. And it's been shown to improve the quality of care and the satisfaction with care. And that's exactly what this is, programs like this. We make handouts and reading materials for you in the clinic. We do shared decision-making, where you come to the office and we tell you about the curve and how it progresses. With Stefan's work, what your likelihood of progression is, hopefully something we will be able to talk to you about in the future, and what that holds for you. And we talk. You give us feedback, what you think, what you fear, what you don't fear. And then courses like this, Power Over Scoliosis, are really important for engaging you and turning non-operative care that's just not neglect into actually making an observation. Now, what if you choose to watch it? We don't want surgery. We're averse to surgery. What is the natural history? From IO, we know 50-year natural history that these were people who had skeletal maturity, had curves around 60 degrees and lumbar curves around 35 degrees. So the non-rib-bearing spine was around 35 degrees. Progression was slow. And for these sort of, I would call them moderate curves, death due to the disease was really rare. So this is not the child with a 100-degree curve that I think most of us would push very, 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 very hard for you to have surgery. It's the curve where you're mature. It's a large curve. It's going to progress slowly. It's probably not going to take your life. You're going to have maybe a little bit more back pain. But you also need to remember that this is the United States and back pain is ubiquitous. Everybody gets back pain at some point. And only about a third of the patients felt limited by their scoliosis. And the limitation was not really related to work or anything. Their primary complaint was the deformity in buying clothes that fit. Now, we always, when we look at cases like this, you like to make sure that what someone says is validated by other people. And the Iowa experience that I just told you about is consistent with the experience in Sweden also. Progression was slow. Huge progression does happen, but it's rare. But as long as you're engaged in the care, huge progression should be fixable. Back pain was a little bit more, but again, it's not too bad. And perhaps if you looked at the population as a whole, it's really, the more and more we're learning about pain, that pain, it's the perception of pain and how you deal with pain and how you cope with pain that really affects how the pain goes moving forward and how much it affects your life. One thing that was important to note is that the sort of the in-between curves where we say maybe surgery, maybe not surgery, 20 years out, the people who had surgery actually felt a little more limitations due to the fusion. No more pain, but did feel a little bit more limited because their spine was fused. So important to remember that surgery can be done later. I don't know that we don't want them to get to be 100 degrees, but also in 20 years, I tell my patients now that, so I treat adults also, if I'm doing all of my surgeries the same in 20 years, we have done you a tremendous disservice, that we have not advanced either the safety or reliability or judging how to correct and where to correct. So hopefully in the future, technologies will be different, so perhaps even we'll look back at what we're talking about today and say, yeah, I remember when we used to do that. Very quickly, bracing works. I would choose a Boston brace or a Rego. Aim for as many hours as possible. I tell my patients the more the merrier. Aim for 20 hours a day, so I tell them that the 4 hours is like money. So don't wake up and spend your money right away, because later in the day you're not going to have any money when you really want to take it off for sports or whatever it is that you do in the afternoon. So try to save them up and wear it as much as possible. Spine core looks nice. It's not a plastic brace, but been shown to be ineffective relative to the others, so I would wear the others. What about exercises, muscle strengthening exercises? The Schroff method is probably the most popular. It can certainly be used as an addition to bracing. I would not use it as substitution for bracing. There's some in our science, some limited evidence that says maybe it works. I think the difference in groups that did the exercises and didn't was very small, and they don't really follow the curves long enough to know, are they going to spring back? Ultimately, though, really the question is, it's safe. It is certainly safe to do it. It engages your care. And also, both for patients and parents, I know that you want to do absolutely everything, and you don't want to carry them to the point where we say, well, now it's time for surgery, and have any regret. You don't want to have decision regret. So if you want to do exercises and things like that, and it makes you feel like you're doing the absolute most for your child, I think it's perfectly appropriate. Chiropractic care. I don't think there's any good data for chiropractic adjustments. Josh has a very nice picture coming up of a patient that chose chiropractic care rather than bracing for their scoliosis. While there's no good data to support it, the converse is true. There's no good data to really refute it either. We don't write about it. We don't investigate it. I wouldn't even spend my time or money to investigate it because it does not conceptually make sense to me. One thing I tell all of my patients is don't let them manipulate your neck. No neck cracking. We have strokes. I've had paraplegia come into my office before from chiropractic manipulation. Acupuncture is another non-operative thing that's been talked about. There's no evidence to support it. What's the cost? The cost is probably what your copay is or whatever you have to pay. That's the risk, is that you're losing a little bit of money, but the actual risk to you is none, provided you're not doing that on the hope that alone, no bracing, not going to the doctor, that it's going to fix the scoliosis, because that's where observation turns into neglect. What about vitamin D? This was a big talk at our meeting last year. They haven't published the paper, so we haven't been able to go through it as sort of scientists and critique the actual work. But they showed that those girls, particularly those with low vitamin D, which is a very common problem, just like back pain in the United States, low vitamin D is extremely common. Particularly those who started with low vitamin D, they took a vitamin D supplement with some calcium, and the progression in a brace was slower than if they wore a brace with no vitamin D. So I don't really believe it yet until I've been able to see it carefully. But again, what's the takeaway is that vitamin D and calcium are safe. The vast majority of adolescent idiopathic scoliosis that comes to our clinic is a young woman. Premenopausal calcium intake is the most important thing for the calcium content in your body after menopause, which for all the young women in the audience is miles away, but it'll be here before you know it, and there's no harm with taking it, and it might help your scoliosis. So every kid I put in a brace now, I also recommend that they supplement with a vitamin D and calcium tablet. So, in summary, so when a curve is below where we're talking about surgery, bracing works. Vitamin D supplements may or may not work. We don't know yet. It's probably not harmful. Scoliosis exercises may or may not help, but they're probably not harmful as long as they're an adjunct to a Boston or Rego brace. And I think observation alone, so long as you really understand what the history of what we're doing is not that bad. Thanks.